All right, Vahan. Uh, Obviously, I know you because I did uh gift and most of the Great Institute course. But still, for those who are not familiar with who you are, can you like introduce yourself a little bit?
Sure. My name is Vahan Agbabian. I'm an athletic trainer, certified and licensed. I've worked for 38 years in the field. I did undergraduate education at Albion College, graduate work at Western Michigan University, was a gift fellow in 2014, and did PCM in 2017 and 2020. And Dave Tiberio and Gary and Ernie and I film the foot and ankle specialty. And Ernie and I present live courses. And Ernie does it by himself in the fall when I'm with football and can't go. But we actually are going next week to Savannah, Georgia for a foot and ankle live specialty seminar. So we're looking forward to that.
Nice, nice, nice. So, what like before we dive into like the injury questions, all those stuff, I want to ask like what make you want to go into the whole Gary Gray stuff, Gray Institute gift.
Being older, being 64 years old, I attended back then what was Win marketing courses before they became the Gray Institute. The first one I went to was Chain Reaction in 1991.
Oh,
And I've been to like seven chain reactions, and I'm doing my eighth one, The Future of Human Movement, right now through the Gray Institute membership. So I heard a lot of different courses. They went chain reaction plus, chain reaction explosion, 3D, and they kept adding different types of uh, chain reaction evidence based, and they have gotten to this point. And I was at one of the other courses, and he was talking about he had worked with some people in the physical therapy schools to try to get maybe some curriculum changes. And then there was some frustration with insurance reimbursement for things they were doing when, he was owner of his own clinic in Adrian, Michigan. And that's when I first heard that we are going to create our own credential. And this is where GIFT came from. And I think the GIFT class number one was 2007 or eight, I think. And then if you add, you know, a bunch of years, and we get to 2014, and I'm class eight, so maybe 2006 or so. But and I know some people that were in that first class, so the interest has always been there. Taking a lot of different weekend courses, hearing Dave, then hearing his sons, and then gift became a natural choice, and after that PCM became really natural. Ernie is a facilitator too as well. I think this is fifth straight year, so I have not facilitated, but he has. Working collegiate football at the FBS level, it kind of eliminates like, hey, I need to miss a Tuesday or Wednesday through Saturday twice, during once is right in the middle of the season. So that's really hard to do. So I actually did gift when it was on a bye week, and PCM also hit a bye week too, which made it very, very convenient for me. And also was one of the reasons I signed up immediately at that time, looking ahead at the calendar. So that was a great question.
nice, nice. So, uh, 38 years of experience in our field. Um, I want to start by asking you this, because I talked to Gary Gray, Dave Tiberio, and a lot of like legendary coaches like Coach Boo Boo Schixnader, Dan Paff, all those guys, and they've been in this our industry for like at least 20 or 30 years. So my question to you is like, with everything changed in like at least the past 10 years, technology been a huge part of our like day-to-day basis, force plate, catapult connects on whatsoever. But the interesting thing is like injury are getting like we're actually getting more and more injury. So, uh, what are we missing or like what are we losing?
Boy, that's a massive question, huge question. Let me start with this. Let me answer the first half, the technology part of it. Lot of awesome technology. Obviously, Gary, since I heard him in 1991, empty room concept. What would you do if they put you in an empty room? And I still use a lot of empty room concept. Our training room had what, a $3, $4 million makeover, and our weight room is going over getting another $4 million makeover. So as technology, has progressed and we have all this equipment, electrical modalities, scanning and assessment equipment, cameras, force plates, things, is to use the technology and make sure we follow the old adage of use the tool or the technology and don't get used by it. I don't think there's anything wrong, with using the technology. Ernie and I see different patients. Ernie will see more people that are over 70 years old, where, 75, 80% of my week, I'm with collegiate football players. That's a very different approach. Ernie has less visits while I see people every day. And we're in a training room where the expectation is to use the technology we have. I just make sure I don't get used by the technology or we get sucked into having to do multiple things and I burn all the time that I would have with an athlete and it doesn't get me doing what I need to do to get them back rehabilitatively. And then we have to make sure that part of that rehabilitation process is reintroducing them into the weight room and strength and conditioning and the practice field. And there is obviously a ramp up of practice before we can send them back with the ultimate goal of we would like to put them back on the field as good or better than before they were injured or before they presented with some type of condition that was affecting performance. Uh, why do we have more injuries? I think that sometimes we try to get maximum use of the calendar. We acknowledge recovery and we acknowledge rest, and yet want the guys training and competing and practicing 11 months a year. And I will stay with collegiate football for a year. We're going to shut down here in May for the most part, yet medical is open 9, 10 hours a day. People will still come through. Now, if this is a normal year, the weight room is still open and people are still coming in. They're still running. Quarterbacks are still throwing the ball. Can you train 12 months a year and include competition and practices and camps and all the things they have to do without being, too run down? This is my sixth coaching staff I've worked with and seventh strength and conditioning staff. And the strength and conditioning staffs have been all over a continuum. They all have been very good in their own way. They've been good about working with us with injuries, but a lot like to do certain things that maybe the previous staff either never thought of or wouldn't do. And I think we have to make sure, particularly if I give an example of like hamstring strains, to remember, and that's a big frustration both collegiately and in the NFL. Although I've never worked in the NFL, I just hear that as you talk to other professionals, people in sports medicine, strength and conditioning coaches, people that were former players that are now in there go, yeah, hamstrings are a real bugger. And you know as well as anybody all the different things that the hamstring does. And there's no one test. You have to test all the functions of the hamstring. And it will have a time based thing because if you try to rush it, they'll re injure it again. And the technology can be helpful if you use it correctly. But if we rush it or try to have a machine tell us when they're ready, I think that's a mistake. And that's an example of where, other things maybe we're more successful with, but that one has been a little bit of a bugger,
Yeah.
you know. I'd love your opinion on that.
Yeah. Uh, I don't know. I feel like kind of the same is I feel like we get so caught up of like force plate or board when my experience with it is like solely using Nordboard or Nordic hamstring curl to prevent injury. It's somehow gonna make it worse. Change the sprinting mechanic, change the direction or deceleration mechanics. And yeah, that it's gonna make it worse. And even with force play, I have athletes that you can't easily see can't decelerate on like certain leg, but on force play it's almost perfect. So I personally like to look at how athletes move and like what you said, work back, like start from function. And yeah, that's how I approach like injuries, especially I feel like and I do feel like coaches get so caught up with numbers and they try to chase output that potentially like increase the injury risk.
Well stated. Very well stated. Another thing too is position specific. If we take a marathon runner, they're not going to do a lot of retro training while our defensive backs, unless they're on a corner blitz or trying to fend off a block, are backpedaling over and over and over again. Quarterbacks got, depending what type of drop they have, what type of offense are they under center, are they in shotgun, do they move the pocket a lot? And so different demands on their foot and ankles, their knees, their pelvises, their hips, their thoracic spine, and their shoulders because they're handling the ball every play. Linemen have their butt up in the air, and they're in a 3-point stance, and their knees are in valgus, and because that's normal for their position, and they're going to drive more when they run block. And so you can't avoid that. So you're saying, what creates more valgus? You've got some frontal, some sagittal, but that rotation really cranks it in, and they've got to be good rotators. And you see things, going back to hamstrings, where certain equipment keeps them completely out of that. And that is part of what they do. And so for our big skill and our medium skill and our fast skill and our ball handlers, offense, defense, our kickers, not only do we have to, think about their function, but then their sports specific function about how their hamstring is duressed. And for example, place kickers, punters, people that do kickoffs, they may not be symmetrical. You cannot chase symmetry because they function asymmetrical. Plant leg, kick leg. If you're asking the kick leg to always do what the plant leg does and vice versa, we are chasing a number and we will chase a problem. And I think some of the specialists that know what they need to do to keep that, how you want to say, that efficiency while being asymmetrical, they don't get hurt unless we throw them into the bench or some where they get a late hit or a block where there's a penalty and they just get lit up. If they're allowed to be, they do well. Receivers have to run to both sides. But linemen on either side of the line, if you're always right guard or right tackle, you may not be symmetrical in everything, especially with, pass blocking, run blocking. Center may be a little bit more right and left equal, and running backs the same thing. So as you tear apart the positions, and then you start going into other sports, people that work soccer, ice hockey, wrestling, people that work military, or in industrial medicine where people have manual labor jobs, load boxes, drive trucks. Then you've got further demands, and these people are not in sports 5 to 8 years. They work 40 years in this environment. So you got the long term types of things that happen from a chronic aspect. So you bring up good points. Good points.
Appreciate it. So, next question I want to ask is since you brought up hamstring, uh, I mean, so this is what I think. So I think in the last 10 years, basketball, I don't know about football, but basketball definitely are getting more and more hamstring, more and more like adductor strain and calf strain. And like I said, potentially it's because uh the speed increased, the game speed increased, the tempo increased. So, and it used to be only like track or maybe football have those type of injury. So, in your experience, let's start with hamstring. So, let's say if a wide receiver like have a grade 2 hamstring strain. So what is your approach to the grade 2 hamstring strain?
The first thing is, to make sure we have an accurate assessment. You know, I work in a situation where, our team physician is going to get a look at there. There'll probably be some imaging. So we'll get a good diagnostic of where this grade 2, strain slash tear is. And then, we will use our technology in the treatment. You can't just send those people into the weight room right away and load them up. They'll be limping for the next excuse me, for the next month. So we have to get some tissue calming down, and we have to restore, normal ADL function first, before. And I would say I would not do a lot of isolated or any isolated loading like that, because I don't think that's going to help it. So I'm not going to Nord board them. I'm not going to do a hamstring curl. You would try to integrate that and actually go for pull the friends in and give it a lot of help. And, you would think about, okay, of all the things the hamstring does, I'm not going to lay them on a table unless I'm going to treat tissue. There's certainly things, if I get specific, there's different types of stims. You can use lasers, you can use your hands, ice massage. Water does deload early on. You can still get them moving, in the water. But once you get them calming them down, then you can increase, a weight bearing load, so to speak, body weight before additional weight. So I'm not loading with weight vests or bungee cords. Every athlete is going to be a little different depending. Is this their first one, or is this their fifth? Because they're going to be a little bit more timid, probably if you have a fifth, and there's probably been more scarring there. And this is where your skills with your hands are important, to try to feel and to look at the scans to see, how much scarry, grungy tissue do we have there? Is there a defect? Is there a divot? Uh, I'm not against testing all these things for the hamstring, but I think the most important ones are the ones that match their sports specific and ADL needs. So obviously, lunging, stepping, squatting, balancing, trunk flexion, rotation, and sideways control. Hamstring works in every plane and in almost everything you do on your feet. So if you're lunging, you're going to have to go in every vector. And obviously, you can protect it a little bit more if you stay more extended or side bend away, maybe. But if you start flexing and rotating towards, you're going to really hit that higher hamstring. I like the true stretch programs. I like dynamic warm up. A thing that isn't talked about a lot anymore that I learned earlier in Gray Institute and Win Marketing courses is the use of that walk and jog matrix, which is very good. And, safety syntax, change your foot position to offer help, and so that you can take stress off a tissue. Certain stances with certain reaches and certain loads are going to put way more load on a hamstring. Things have to be progressive based on success. And I know I'm talking to the choir here a little bit, because you use that too. And I don't know if you can be totally time based, except for the fact that you're not going to get a grade 2 back moving at full speed in a week. So don't bother trying. That's just not happening, unless something is really, really, they're either extremely unique in their healing, or the
Or they really want it
diagnosis.
back?
Yeah, and they're not going to be full strength. They're going to be out there at 50% or 70%. And different positions can protect themselves a little bit differently. A running back, this is not going to happen. And since we're talking wide receiver, thinking of the speeds they have to do and block, and then cut and pivot on a dime, turn, catch, jump, and they don't land nice knee over toe. They could land in any direction. That is one of the more difficult positions to rehabilitate because of the speed, and they could go anywhere on the field, anywhere. And so you have to make sure that the tissue can handle each progression, each environment. and that we don't get lost or derailed. And I'll say this, I think, like, for example, use of a valve slide or the 3-act or a slide board is tremendous as an additional environment. But it's like if I want to take my receiver and start skating them, I'm getting farther and farther away from playing on natural grass or artificial turf. If you're really into using the Bosu and you stay on that thing a long time, you're talking about a dynamic movement on a dynamic environment. And the football field, for the most part, is a static environment, minus rain or ice or snow. But normally, especially with all the indoor fields, you have to be dynamically solid with your mobility and stability on that surface. So the surface is not moving. So that's where a lot of the rehab and training needs to take place. It doesn't mean you can't delve into the other areas, but if you start staying away from the football field as an environment, I think you miss the point a little bit. And so that means you have to be careful with the equipment you choose. Yeah, we squat, we leg press, we do lots of things. We use step ups, body blades, kettlebells. There's many, and no equipment.
Mm.
FMR, perturbate, whatever. There's a lot of things you can do to stimulate, to give success, and to give the hamstring not only a chance to heal, but then resiliency before performance. Because if we jump too quick to the performance, they will re-injure again. That's going to happen.
Nice, nice. So, uh, I feel like one thing that our industry don't like, or probably everyone don't utilize or don't emphasize enough is like the basic skipping, jogging, or like we talk about like different positions, different foot positions of like jogging, walking. It's really basic, but I don't know why like coaches, physical therapists, or even athletes, we don't utilize that enough, especially in terms of like return to play. So, uh, talk to me about like if it's a hamstring strain, like how fast would you ask me to do like just basic like maybe like toes in jogging, toes out, or walking, or like skipping?
The obviously, they're gonna walk a little slower at first. Then we get to standard pace walking, and then maybe you start playing around with the walk matrix, which is basically changing your foot positions. Like a inline walk or a line over walk, a wide base walk, sideways walking, walking karaoke, things like our karaoke. These things first, skipping now creates there's a flight phase there. So there's going to be more force production and some more impact to absorb. So if they can get to the point of skipping, and sometimes with some of the movement patterns you learn in PCM, like skip buffles and things like that, you can skip off the other leg and just land on that first. So it's two hops or two skips on the one leg, and then the walking leg, because it's kind of basically a skipping shuffle, and the only flight phase is on that uninjured side first. So that's okay, but it's going to be. I don't think you're going to be able to have a flight phase a lot of times within that first week if we truly have a grade 2. If it's misdiagnosed where it's a grade 1 and you think you feel a divot, but it's really swelling, and they start moving along much better, without imaging to prove that, it may just, well, we thought it was a grade 2 and it's a lot less severe, and so they're going to progress faster. And I think to move them in the manner which you say, going from walking faster, and then movement patterns before we add the flight phase, is a very good progression. And the only way to do that is to test to see, is their tolerance, how fast do we get them to their threshold. And we have to clear other things. If they got a really gunky hip, bad hip flexor, pelvis doesn't move, uh, bad foot type, all of a sudden, like, no one's ever taken my shoe off before, and they just have a foot that's very high arched pes cavus and the thing just doesn't move very well, they don't shock absorb downstairs at all. So that has to be looked at. I will say this, having a chance, because the Michigan Medical Center is a teaching hospital, we get a lot of students and we have fellows and you get residents and things like this. And a lot of times when you teach them the safety syntax and say, hey, we've got 27 symmetrical stances and 36 asymmetrical. So I've now shown you 63 different stances. How many different ways do you have to squat? And their eyes usually get really big. Well, yeah, sometimes I go wide or I go narrow or I go standard, but and I say, well, you've already done this. If you do a rear foot elevated split squat, you've already changed your stance and you're not toe touch. Your leg is usually in contact with a box or a bar, or they have the special little roller pads for people. They do belt mobilizations and things, but you can do a split squat. That is changing your stance. And when you think about it, okay, we have 63 different stances now for squatting. I may not put a back squat and use some of those stances, but I'd have them hold a kettlebell or dumbbells and do that, or a big weighted ball. And when you start thinking toe touch on one side for 63 stances and then toe touch on the other, and then no toe touch, you've got 63 times 5, you get 315 stances. And that really kind of opens their eyes a little bit to say, we have more than one way to move. So let's find the ones that are treating the hamstring a lot better, a lot more gently before we ask them to do something very difficult.
Nice, nice. So, uh, before you dive into like uh different injuries, um, I want to ask because talking to different coaches, obviously, everybody had different experience. So, uh, when it comes to like hamstring strain, what are some common causes you see
It,
that
it you
causes
know
a hamstring strain?
in the collegiate setting, and this is almost laughable considering, when I first started working football in 1999, the rules, we had no fuel stations, no snack bars. You had like water, Gatorade. You fed them one meal a day. So a lot of guys come in the morning. What do? They've been out late, maybe. They don't eat breakfast. They come in, they're not very well hydrated. And so there is a big cause of the strain. We have dehydration. I think our warm up that we do is much better now than what it was a long time ago. Jogging around the field and static stretching and then a little bit of agility could be okay for some people, but then you start pushing the tempo, and the whole philosophy on hydration during practices has changed many times. Think about 70s, 80s, 90s, 2000s. Water is available unlimited now and has for a long time. We cut a lot of injuries just like that. I think we have to be careful if we bring people into the weight room and warm up because of time is reduced, and then we start going to squatting and RDLs and then explosive movements after that, or using certain exercises isolatively, especially when we're trying to make explosive movements in the weight room and they are already fatigued. That is, one, two. Also, if we are in a teaching portion of camp where they get warmed up, they do a bunch of stuff, and then they're given a break, and then they do some walkthroughs or something, and then right after that, it's gassers or sprints or something, and now they have to move explosively again, and they've actually calmed down or cooled off a little bit. If we screen right, we should catch pelvises that don't function very well. We screen out feet. We check hips to make sure that these big rock zones, thoracic spines, are moving correctly, that we don't have big glitches or lack of mobility. Because if we start moving them faster and faster and exploding them, they will break down quicker. So there's many reasons why. Another reason is sometimes we switch a position. We take somebody in offense, move them to defense, offensive line to defensive line, or a bigger safety to linebacker, and the demands change, and now they have to cover a different point of the field. Linebackers have to cover side to side, more than anybody on the field. And that creates a lot more coming back to the center, running sideways or crisscrossing, or particularly counters and reverses where they're flowing in one direction, got to plant, turn, and go the other direction very fast. So you see a lot of that with our linebackers. People that work other sports would probably have excellent examples of particular environments that produce the hamstring strains. Another
Nice.
good question.
Thanks. So, you mentioned that uh, there's probably going to be some lack of mobility in the hip and the ankle, right? And
or
there's
or too much, particularly an ankle. We have some of these linemen that are 315 pounds, very flat footed, very super mobile foot. They almost stand in a little bit of valgus. We have to make sure, are we in the correct, shoe or cleat? And I didn't mean to interrupt you. If we're going to use take fine, are we going to support the arch? Should we get them some type, some that lack some dorsiflexion, we give them a heel lift, they get a calf stretching program, calf matrix against the wall. They use the slant board. We roll the arch. We're in the stretch station. They have to get that mobility back. And most screens, regardless of where they come from, all go after ankle dorsiflexion, probably in some way, no matter how they work on it after, but they're looking at it. And if the foot type, if there's 13, 14 different foot types, and maybe 5 foot types are really problematic, probably 3 of those foot types or 4 of them, like 4-foot supinatus, 4-foot valgus, big rear foot and 4-foot varices, you probably need a device, need a biomechanically corrective foot orthotic. And then once the environment is corrected, then the shoe and the orthotic is taken care of, and now it becomes all about the rehabilitation and the training. But that's an environment change that for certain foot types has to be taken care of, or else they're fighting their own mechanics. We're trying to get them stronger, more mobile, more flexible, more functional, more explosive, and the demands overtake what they have the ability to handle and fight back, and the tissue goes.
nice. I'm glad that you brought up like the foot. There's hypermobile or like not enough hypermobile or hypomobile in the foot. That's because I feel like we talk about the jogging or like safety syntax, we don't get enough credit for the foot and ankle when it comes to like lower limb injury. So and I'm actually glad you brought up calf because calf injury is like people are scared of calf injury right now because they're gonna afraid like the Achilles tendon rupture. So after hamstring strain, maybe talk to me about calf strain. How like your approach to rehab. I know it's depends and somehow it's kind of the same like you already mentioned, but still.
The Achilles tendon is very, very strong tendon. If the injury is in the calf itself, the meat of the gastroc or in the gastroc and soleus, now you have the muscle tissue injury. We have to screen out, make sure there's no defect. Again, at where I work and at a professional level, I'm sure as well, if if we find a defect, they're going to image that so we get an idea of the length, how many millimeters or centimeters is this defect? How deep does it go to make sure that we're not doing anything that really irritates it? Many people will have a little bit more, not in all cases, but will create a little bit of Achilles, tendon pathology, whether it gets tight, whether they have. It's not tendonitis, but it'll get sore if they recover and warm up the next day. It's pretty good, but again, you have to take care of the foot mechanics. And, for our Achilles, other than treatment or certain manual techniques, they're not on the table. We have to stand them up. We have to find the environments that are successful. Never ignore the hip, because that origin of the gastroc is, it's oblique. It's on the femoral condyle. So that's part of that hip joint, crosses the knee, only muscle that directly affects three joints. Others affect two joints and then indirectly go all up in body. Calf affects the shoulder and the elbow because of our fascia lines. That's not a direct connection. It's indirect. It affects our chain reaction system. But calf is special because of the three different joints it affects, with direct muscle attachment. So we have to make sure we clear that hip very importantly. And you think about, where does the calf, you stand up and it does everything from calf raise to lunge, balance, rotate, plant, handle surfaces because the foot's a mobile adapter and the calf is in there. That's like the offensive line of the lower leg, and works in conjunction with a lot of other muscles. And you think about the insertion points of peroneus longus and posterior tib, a lateral muscle inserting very medially on the base of the first ray, and the posterior tib starting very medial, and the insertion tendrils are on metatarsal heads 2, 3, and 4. So they crisscross underneath. Their combined functions with the calf complex behind is way more involved and complex than their individual non-weight bearing functions. So how does that calf coordinate with everything else? And if somebody's got a bad toe, they've had turf toe, they got bad callus formation. Well, I've had a couple of medial stress syndromes and I've had posterior tib before. Then you throw in ankle sprains. Now you're looking at calf. You got a whole foot and ankle complex that you're looking at. It's not just how many times you calf raise, but you push a sled or you move a body out of the way with blocking and you get up on your toes, that calf is firing as a big time plantar flexor. So depending on your sport and position, it's going to have a lot of demands. And if you're a backwards peddler, like a D-back, a safety or a linebacker dropping, now you got all this eccentric load. And then you may have to plant your foot and go in another direction, like on a dime. So you have a big eccentric load there too as well. So a lot of different ways to go after the calf. If I had a specific time frame, I could probably give you some specifics of what I like to do, and so could you. But talking in general, we just have to remember all the things that the gastroc does.
Nice, nice. Uh, so does that mean like you basically start with more functional, like you're probably gonna start weight bearing, like just walking, jogging, like right away?
If they ambulate with too much compensation, if they limp, then they get crutches because we have to normalize the limp. And then when I say weight bearing, we will either hands in between the tables or on the crutches where we deload or put that foot down and then move the other leg because you can create motion by lunging the ineffective leg in certain directions, but we have to deload them. This is where a total gym is nice, or I we have shuttles which are I like them. We do use them. We got rid of our total gym. I liked it because you can go very low level and get some low load where you get like the plate reaction. Now they are on their back, but you can, deload them where you can get a squat, change their foot position. You can put the BAPS attachment on it. And early on, you can really deload and protect the tissue, yet get the movements and the stimulus that you want without overloading the thing. Because if you see them on Monday after a weekend injury, and on Friday they're moving no better, that's not good. We just lost a week at that point. We should see some improvement. Just like if you took a fresh, uninjured body and you start working, you want to see some improvement at certain levels. You may not get a strength improvement in a week, but we should be able to get some functional improvements. If I'm seeing them every day, 5 days, that's not their problem. That means I'm doing a bad job. If we don't get improvement, that's on me. So
All right, so let's talk. This is tough, but let's talk about timeline. So if it's a grade one calf strain, usually how fast does it need to go back to play football?
if we're talking a receiver at a grade one, if it happens in the game, Do they have a chance to play the following week? Maybe. But here's the deal. And this is kind of depends on the coaching philosophy too. Some coaches, if you don't practice Tuesday and or Wednesday at least, you can't just come in for the easier walk through Thursday, Friday, then go out and play and rip it up again. They're not going to let you do that. So, I would say maybe more often than not, maybe they miss one game. Now, less than grade one, if you treat it and you protect it and you use sleeves, you change the shoe environment, maybe cut some of their repetitions, or say, look, we're not going to have you play 58 snaps out of 90 on offense, and that depends on the tempo and what you do. Maybe we're going to try to get you for 20 snaps if you can handle it. So the overall, what you would call the workload, the work capacity they have, but I have seen somebody, they have a mild strain where they end up playing the next week. But if it's by Wednesday and they can't run, or Thursday, they will miss a game. Now you're getting into next week. And it's amazing what an additional Friday, Saturday, Sunday, Monday with treatment and work can do for them the next week. So, grade one sometimes misses a game. You get into a grade two, you know, you're going to miss a couple, maybe more, and hamstring seems to be worse. If I jump there again, a grade two hamstring may miss 3 games, sometimes two, kind of depends. Are you two right on? Are you two plus? Are you two minus? Are you one plus? How can you manage? How can people go out there and play within themselves? More experienced players know where to be. They anticipate because of the game. So they're more efficient in their movement. Tremendous athlete, less experienced. They try to run everything down. They have to go everywhere as quickly because they depend upon their physical superiority to play. It's amazing. You have older athletes that are veterans, particularly professionally, still manage to get the job done. And yet, well, I've maybe lost a step, or I'm not quite as strong, but I know where to go. I'm really comfortable with the defense. I know where my help is, and they're still very effective players.
Nice.
So there's a lot of stuff. I'd like to hear your opinion on that.
I don't know, because if you ask me about hamstring, I think hamstring is easy. I don't have a lot of experience with calf, just being honest. I think hamstring is actually, because I have a track background, I think
Mhm.
hamstring is actually one of the easiest injury to rehab, hamstring and ACL. Uh I think people make it more complicated than it is, but somehow I feel like if it's grade two, I feel like 2 to 3 weeks, like you mentioned, miss 3 games okay. I think that's like perfect timing. But if you look at like basketball, like grade two, they're probably gonna miss like what, 2 months. That's crazy to me. So yeah.
Different, think about a 6'10" forward with their long lever arms, and the nature of basketball with continuous play. You start moving slow, and unless the coach calls a timeout or you get a television timeout or something, the team will just blow right by this guy. They'll put 6, 8 points on you like this. So and they move differently. 5'8" running back with a hamstring strain, versus a 6'10" center. Or think about a female, volleyball player, basketball player, 6'5", 6'7", different pelvises. They can train and be very neuromuscularly sound, but they're just built differently, recruit calf differently, and some can move differently, and it's more difficult. I agree with you on the timeline, absolutely. And sometimes if you miss 3 football games, could you miss 9 basketball games if you're in a certain travel where you're playing 3 games a week, then two the following week, then three, then maybe one, you could miss 8 or even 9 games in a 3 week plus. Now, if you're playing 82 regular season games, 10 games is a little less than 1/8 of the season. Start looking at it that way, and considering salaries and what is expected of staff to keep these people up. You're trying to do everything you can in the off season, make sure it doesn't happen. And then we got to make sure that we don't overdo it. Can't underdo it either. Can't go off and say, go to Hawaii for 3 weeks and do nothing. That may be great. But when they come back and start working again, it's not happening.
Yeah.
So it's
So
tough.
can I understand this way? So grade one capturing might be like 1 to 2 week. Grade two capturing is it like maybe 2 to 3? And grade two hamstring might be maybe 3 to 4 in your opinion, in your experience.
I think it can be 3 to 4, and it mostly depends on. I think a lot of it is on the kid, assuming they come in and do everything we have them do, and they show up and they sleep, recover, eat, hydrate. They do everything perfectly. Then it's a matter of, does the position allow them to play at less than 100% effectively or not? And most of these collegiate athletes are all over the place as far as pain tolerance. Some can just play with some more discomfort and are okay. Others will just go, nope, can't do it, not ready, or won't. It's like people with ACs, even grade ones. They're just, some people can go after a week, or they get it padded up, or they get some medicine and they're okay. And the other person goes out there, they have one bit of contact, I'm done. So
Hmm.
there's a little bit of dependency there. And as you know, the longer you work with your athletes, you get to know them as far as their pain tolerance, what they can get away with and what they cannot. And I agree. I think we have so much information on ACLs. If we're just smart about it, they just come along, give them the time, and they'll do great. I don't think hamstrings are a big secret, but we seem to continue to have problems. And I do think we do chase the data. Whether it's handheld dynamometry, isokinetic score, Tindeck, or manual muscle test, or what does the ratio on the on the Nordboard say? If you want to use numbers, that's fine, but be careful. It's like people. I remember the athletic department. We brought in the nice people from functional movement systems, and they came in, and everybody got FMS1, level certified. And all of a sudden now, 10 years later, at a course, what is designed to test healthy people is now part of a return to play, and you can't get a 1, and you got to have a score of at least 14. I'm like, and when did this happen? And what I want to hear, I'd like to hear the FMS people go, boy, that's not designed for that. It's not why we put that together. Have I heard that once? No. Even going to the Perform Better thing in Chicago this past summer, we were there in June, and they brought that up, and you don't get an answer on that. And I'm like, that is not designed as a return to play. The upper extremity, if a lot of people are tremendous athletes that get a 1, you're telling me we're going to fail them because they can't put their hands together on that? That's ridiculous.
That's actually a good point because I actually came from a FMS, then SFMA
Yeah.
background.
Okay.
And then so I think it's like 6 years ago. 6 years. So I did my FMS, SFMA like maybe like 8 7 8 years ago, whatever. Then 6 years ago, I was doing uh 3D maps, I believe. Back then I
Mhm.
was like, this is just some fancy stuff, not really work. Doesn't really work. But what's interesting is like I fast forward like last year. I started to do the foot ankle specialist, and then I was like, okay, this is interesting, and it's really helpful. So, like you mentioned, like I do feel like FMS not enough. We need more functional ways to assess and to really figure out what's the problem.
Agree, 100%. And that, if you work with figure skaters who are on ice, their forest is different. If you're with swimmers and they're in the water, divers who go off the 10-meter platform are in a free fall, for doing all their 2.5 with a twist, going backwards, forwards from handstand. That's different than our ice hockey players, from our cross country, our soccer players, our court and field sports. Do you have a stick, a racket? Is there an implement? Is a ball? Do you handle the ball in every play like the center does in football, or you're a defensive end and you get your hand on the ball because you batted something down or you fell on a fumble? A lot of times you can go a half a season and never touch the ball ever. That's a big thing. And then you start, we haven't even touched on like all the stuff that's out there for neurocognitive right now about, you know, you know, trying to separate all the different distractions and think about it. Football has plays. There's a start time, stop time, change the groups. Where hockey is free flow. You can substitute while the game is going on. It just constant time unless the puck goes over the board, there's a goal or penalty, or the board or the glass breaks or something, or injury. The clock just runs. Continuous play. That's totally different. Constantly. 9 other guys plus 3 officials you got to be careful of, or you run into them unless you're trying to run into them. So the different types of environments in sports are so different, so different.
Yeah, I want to backtrack a little bit,
Yes.
go back to timeline.
Mhm.
So, what about Achilles tendon? What about ACL? Your timeline from an Achilles tendon rupture. If we purely talk about timeline.
I I think that the earliest that I've seen one of our collegiate players get back, even if we're doing everything great from passing the return to play testing and getting on the field and be confident to do their job at full speed, is minimum about 10 months. And I think at a year they're better. So if we had a rupture the first day of spring practice, then I would expect them to be, much better by the beginning of next year's spring practice. Now, they may be doing drilling and higher level rehab before that, but they're not going to be getting in a game, especially not as a collegiate. Why would I do that to somebody? And I'm not making that call. That's for our, I'm a rehab specialist for our football program. I am not the head athletic trainer, and I'm not the team physician that did that. Those two are making the call. And we can present them to the coach and say, they've passed all the return to play. They're competent on the field. They're moving at full speed. Now they're return to practice. And if they choose not to put them in, that is the coach's decision at that point. He wants to see more from them, so that can add time or not, depending. So I think, 10 months, super duper rehabs, maybe 9, but to say, oh, we're gonna, get them back on the field at 6 months and they're gonna be 100%, I don't believe that. Not when most of them are gonna, they're gonna splint and cast that thing and go to a boot, because the foot surgeons, for the most part, are way more conservative. They don't want you to force the motion. They want the time. They want strength. They want their calf raise programs. And then everything else you do is fine. And they want very meticulous warm up. So you can't push that timeline. We've had people, go back and play ACLs, tailbacks, 7.5, 8 months. That can be done. But if you have a good foot and a good hip, good pelvis, good thoracic spine, and you get them 6 days a week, yeah. If they go to a clinic twice a week and they get 8 visits a month, 8 months is not happening, especially for high schoolers. Not a chance. They just don't have enough reps, too much on their own. The school athletic trainers don't have enough time to give them an hour and a half or an hour a day. And most insurance plans are not going to let you come there for 24, 32 weeks at 3 times a week. We'll give you 40 visits, maybe. That's 20 weeks, 5 months at twice a week, 2 days out of 7. That's a lot of on your own time.
Yeah.
It just, that's different. Do you work professionally? I don't know your work
Yeah,
environment.
yeah,
Okay, who do you work for? Can you tell us?
yeah. I'm with Grand Rapids Gold and Denver Nuggets.
Okay, grad. Okay, excellent. So you work with professional athletes. If you said you're going to work with them twice a week when you get them, that would not cut it. So high school, 1 person or 2 person in a 2,000 student high school with 20 sports, twice a week they have to go to a clinic for the acute care, and they don't have that equipment to handle acute care. They may not have game readies or electrical stims or things that you need, ramps and stuff. And they just can't take the time because they're dealing with math. They got seven events going on at the same time. You got people prepped, you got management of certain things. And unless you have at school, you have maybe a rehab hour or they're allowed to come down at study hall or something, then maybe you get 45, 50 minutes. Nice compliment, but twice a week's not going to get that done.
Yeah.
So
I,
that difference.
I'm happy you brought up the context of the timeline because every time like when people talk about timeline, like like it's a lot of debate about different timeline, like 6, 8, whatever. But I like you mentioned that uh what we do, we treat our athletes every single day.
Hmm.
So it's already different than like most of the research do, most of the clinic. Like they don't get that rep. And the rehab we do is different than uh a high school basketball player or like weekend warriors are gonna do, right? Our rehab is gonna prep the guys to play high level like competitive sport. So it's gonna be different.
Yes,
And another thing I another thing I'm like I want to talk about timeline is because I feel like we are getting like practitioners are getting more and more myopic at the injury site instead of like we knew like you talked about earlier, work on like recruit his friends and work on the proprioceptor. Because if you don't work with the proprioceptor, either way, he's gonna get re-injured again. It doesn't.
absolutely.
So that's why I'm
Absolutely.
like, that's why I want to talk about timeline.
What other any other specific injuries, for timeline? Just curious.
No, I think
Hamstring.
those are the
Okay.
like hamstring, calf, ACL, and season are the type of injury that people debate a lot. But yeah, I think first of all they don't get that amount of rep that we get, and they don't do the same rehab we do.
If we have somebody that gets a grade one lateral ankle sprain, not a deltoid, not a syndesmotic, so it's not a high, no avulsion, no fracture. You get a grade one ankle sprain. If we do a good job treating them Saturday after the game or as soon as the injury happens, now if they play the rest of the game, then we've got Sunday and Monday. I think that person is most likely not. They're in practice and they can contribute in that other game. Now, if it's a grade two, where and this is where the initial management. If somebody throws them in a boot 3 days before I'm allowed to do anything other than table treatment, no. But if I can get them and if I can put them in the ice bucket and I start moving them and I get them in the stretch station and the BAPS board, and then I can still use my technology, I can treat them in the morning, 2 hours active exercise, and then treat them at night. Maybe they miss a game, but if it happened in game one, game three, they're back and they're playing at a high level. I don't think that a second degree should go on. I have heard protocols where they talk about 5, 6 weeks, 7 weeks. Can you
Six
imagine
weeks,
basketball?
6 weeks is already fast.
No, it's ridiculous. I
Yeah,
just, yeah, I mean, they may do much better if we did nothing, if we're doing, 6, 7 weeks. And if you're talking basketball, let's say high school basketball, they only may play 25 games, 28 games. 6 weeks, they lose 12 games.
yeah,
That could be just under half a season for an ankle sprain. Now, if they have no sports medicine care or it took them a week to get into a clinic, those things happen. Not everybody has the access to you at every sport. You know, you work with two different professional teams that have access to you. That's different than I had to wait a week to get in the clinic, or we were in between jobs. We had no health insurance. We had to go somewhere and pay for a couple visits. These are the other things. But if we're talking care, athletic care, that's high level. That should be taken care of. Yeah,
yeah,
fracture's different. Deltoid ligament is different. Syndesmotic is different. Uh, but a lateral that's not fractured, that's not dislocated, there's no mortise injury, it's just a good solid grade two. That is a rehabable type of thing. And if we know how the ankle functions and we get after it, they will do very well.
yeah,
You hear sometimes these people they they injure it on Saturday and they actually play some on Thursday night game. All right, bravo to the practitioners for getting after it. And I'm sure they were sent home with technology and slept with things on. And, there are things that help with inflammation, fireflies, micro units, compression units that they go home when you're passive. They're still giving treatment. And then they come and you do all the right things to take care of active rehabilitation so you have good success. But they have to be safe. You can't go out there and have them like, well, I'm sorry, you came down on the side of your foot, you re-injured your ankle and sprained your LCL, and you fell and sprained your thumb too because you fell down and put your hand out. That's not smart. Then we've rushed it and we've been careless we've been derelict in our duties, I think. And
Nice.
obviously, you're going to get a lot of different opinions with a lot of different sports at different levels. Um, Game 7 NBA Finals, where there is no other game, may be treated differently than Game 9 of the regular season. You know, but with 70 some games to go in the NBA regular season, that may be looked at a little differently.
Yeah.
So great questions on timelines. That's been really good.
Appreciate it. Last question before I let you go.
Yes, no problem.
So apparently, I don't know about you guys, but I think since you're in a D1 like Power 4 college, like pretty high level football school, I believe like you guys definitely have some experience with the motion capture, biomechanics lab whatsoever. All right, so we talk about FMS. What are your thoughts on uh the overall motion capture biomechanics lab?
For if we have to send a person to the biomechanics lab, because that's not for us with currently, and understand in a couple years, as you know, we will go to all scholarship. We've carried pretty large amount of walk-ons where we've had a roster that's been 141, 150 people, and you can feed all those people. You give them medical care, and you clothe them and give equipment. By the time we start, the season of 2028, we're going to be 105 players scholarship only. We have got 150 lockers in our renovated locker room, and we're only going to be using 105 of them now. The building, that's like two less buses of players going places. That will be very, very, different as far as, looking at people. So if we have to send someone to the biomechanics lab, then we get the report from the biomechanist or whoever doing the filming, the breakdown. This is what they saw. This is what their recommendations are. Okay, fine. We have to balance that with our own assessment, regardless of whatever screening we do, however much of 3D maps, however much of gait eval, however much of different movement testing. We test squat, we test lunge, we test balance. And how do we do that? Well, there's different balance tests. I may have an excursion reach test, or we may do the Y balance and do all three directions or only one. You can do it for upper extremity. There are many ways to test balance, just like there's many ways to test function. The weight room, depending on the staff, has used FMS as a screening tool, more or less depending on the staff. We have not been consistent with that. We do have two FMS kits in the training room. We've got a couple of Y balance kits in the training room. We have some Vald equipment. You have handheld dynamometers for grip. You have handheld dynamometers for testing, but we may not test every joint. We probably do more testing with the wrist, elbow, and shoulder. I am not testing the ankle everters with the handheld dynamometer. I find that unless you're trying to measure a neurological improvement from a neuro injury, orthopedically, I find that damn near a complete waste of time. Now, I'm probably going to catch hell for that because other people, I use that on everybody, and you can. That's fine. I just don't find the number. What does that number mean when you get that foot pounds? What the percentage different means what? Because you're testing one muscle in one plane, one proprioceptor, The Golgi tendon organs are bodies that just all they do is measure the length and the contraction. All the other ones are the ones that do compression, rotation, the Pacinians, which coordinate adjacent musculature, and they're more available and more readily prevalent in the lower extremity. These are just shut off. It's like the light switch is just off on all of these. There's no skin pressure, there's no compression, no rotation, no reaction. And I just won't do that. If you want to know how much people can produce force with their shoulder and you want to use it, fine. Use it as a motivator. Grip strength has some importance. That's fine too. So we may use different ways to test. I don't find some of the FMS tests very good. I don't have you want to test the hurdle step over or inline lunge or the squat, fine. The trunk rotary test is so hard. They've now made modifications. Well, if you change it, it's not FMS anymore. If I do 3 tests, it's not FMS. I'm doing 3 tests of FMS. I'm not now getting a score out of 9. It's supposed to be out of 21. For 7, I am mucking with something that somebody created and changing it to use it to my advantage, and then say, well, I use part of FMS. Well, I'm not doing FMS. SFMA has more tests, and then you do the one for golf, and they're checking cervical and a bunch of other ones too. And they have, how many FMS courses are there? I think there's 3, aren't there?
I don't know. It's
Yeah,
been a
there's
while.
a second and a third one for sure. I do use 3D maps. I don't always check all 6 chains. If I see something in gait or another test, I may give them a chain that is more going to be more successful than one I think they're going to struggle with a little bit and one they're going to struggle with a lot. And I may start there depending how much time I have. If I did mobility and stability and filmed it on everyone when I'm in a training room setting, that doesn't work really well. Doesn't mean it doesn't have value. It's just it just doesn't work very well. I may come back to that at some point. So we'll use what we need to use depending on what we need to see, what we need to find. And then we got to make sure that we are charting, progress, that we're giving the athletes success. We should not have a day where we slipped back. If I overload them isotonically or with any load, and I create all this pain that they need to take a couple days off, and we have to do more recovery because I was greedy, that's not on the athlete. That's my fault. I did that. So we have to be, we have to be careful with that. That's another great question. You've had a lot of great questions. Would you be willing, before you turn the recording off, to answer the question you just asked me?
My thoughts on biomechanics lab.
Yeah,
Oh shit, they're gonna hit me.
that's all right. Just go
All
ahead. I
right.
just want.
So, like I said, I uh came from FMS background, SFMA, very familiar with all the table testing, and recently did Franco and the gift. My my thing about the whole like NFL, NBA, Major League Baseball, everybody's doing this uh markerless motion capture is you can't track how the spine move. You can't track how the talus move. You can't track how the SI joint or the pelvis move. When these like the calcaneus invert, the talus go down and in, or the SI like the pelvis, the relative motion between pelvis and SI and the scoliosis might influence the center mass and influence the tissue loading. Those are like a lot of these joint motion are probably the reason that we have hamstring, calf, groin strain, all these type of injury. But biomechanics lab can't check all these. So I personally I think it's useless, but yeah, I don't know.
Okay. I appreciate that. Like I said, we do not we do our own screening in the training room. The weight room does their screening, and then we talk to each other, and those screens have evolved and changed over time. And the screening is only as good as the follow up. If I take all these notes and have all this database and it just goes in a file and we don't look at them, talk about it, or retest them in a year, now we have a new strength staff. So everything that was on file before just went, we just got flushed,
Yeah.
and we start all over again.
Yeah.
Okay, that's fine. I'm not against starting over, or they our weight room is getting completely redone again, because they want different stuff. There's certain things that were in there that they don't use. They want a different squat platform. They're moving the free weights and kettlebell area from one end to the middle. We had the previous strength staff did a lot of tempering, which are these like solid, like large, like roller cans that have handles, and they roll the hamstring and IT band. Previous staff did a lot of this. This new staff, a lot of them came from University of Utah, because that's where our head coach came from. They don't do that. So that area comprised maybe 1/6 of the weight room with mats and tempering type of equipment. That is now all gone, and they're going to put something else in there. So it's okay. They get to make the weight room anything they want. We have to work with them. They have to work with us. Or otherwise, if we fight each other, then we don't have a good product on the field, and both groups are up to be replaced at that point. You just know that. It's a results oriented business. So you document, we all learn things, and we try to bring the best we can for our athletes. And then we have to give them the time, whether you feel like being there or not, whether you're fatigued or not, whether you have a runny nose or not, and whether sometimes we miss stuff, we miss family things. Now, if you have good supervisors and they try to balance that to some extent. You can't just be there 7 days a week, 20 hours a day. Everybody will just drop one day, because that's not good. But it's an hours business, and the highest of highs happen, but there's a lot of middle ground of a lot of grind in between for every sport and every staff. And you're an important staff person with two different sports, and makes you a valuable asset, but there's a cost. And so we have to try to get our sleep and our exercise and our hydration. Then you try to learn and read, do things like this where we get to interact as professionals, and then go to work after that. So it's a
Yeah.
lot. I give you a lot of credit for what you do. A lot of
Appreciate you.
credit.
I appreciate you.
But well, hopefully this has been what you were looking for. That I
Yeah.
just didn't spew garbage out of my mouth
No, no,
for
it's
for
perfect.
45 minutes or
No, it's
over an
perfect.
hour now. So,
It's
but
perfect. It's perfect.
maybe
Appreciate you.
maybe kind enough to share the address or website of
Yeah.
your podcast, and then I can see, hey, what did you keep in, what did you edit out, and I can listen to it just
Yeah.
from a listening standpoint,
Of
instead
course.
of trying to sound like I halfway know what I'm doing at times. So we'll see. But
No, it's perfect.
Eric, appreciate it very much.
I
Thank you very much.
appreciate you. Thank you.
You're very welcome.
I'll definitely have you on again. I enjoyed this so much.
Well, beautiful. That's awesome. And if you make your way into Adrian for one of the gatherings, one of the gift meetings or something, and I happen to be there, definitely we should sit down and have a beverage and talk some more off the camera a
All
little
right.
bit.
All right.
That'd
Thank
be
you.
great. So you're very welcome. You have a nice evening. Okay.
You too.
Thank you. Bye bye.
Bye.